Welcome to the deep dive. Today we're venturing into a topic that affects, well, probably more people than you might realize, but it often stays hidden. We're talking about trichotillomania.
hmm
We've gathered quite a range of sources, medical research, psychological studies to really try and understand this condition.
Yeah, and our goal here, is to give you a clear picture what trichotillomania actually is, where it might come from, how doctors recognize it, and importantly, how it can be addressed. We want to go beyond just listing facts.
Right, provide some real understanding. Okay, first things first, the pronunciation can be a bit tricky. It's trichotillomania.
Trichotillomania. Yep.
So basically, we're talking about this long-term urge, this compulsion, really, to pull out your own hair.
Exactly.
And it's not just like a nervous tick. It can lead to actual visible hair loss and cause a lot of distress for the person.
A significant amount, yeah.
And what might surprise you is the prevalence. Estimates are somewhere between, 1 and maybe even 4% of people?
That's the range often cited, yes. It's more common than many think.
Okay, so let's unpack that definition a bit more. What's really at the core of trichotillomania?
Well, at its core, it's classified as a mental disorder. Sometimes it's just called hair pulling disorder.
Hmm.
And the defining thing is that persistent, often really overwhelming urge to pull out your own hair.
It's not just a choice.
No, definitely not. It's a drive, a compulsion.
I read something interesting that sometimes there's a brief positive feeling right after pulling, like relief.
That's a really key point, actually. While maybe not everyone feels it exactly the same way, many do report this brief sense of relief or maybe satisfaction right after they pull a hair.
Which sounds like it would make it harder to stop.
Exactly. It can create this kind of reinforcing cycle. And like you said earlier, even when people really want to stop and they try, they often find it incredibly difficult to control that urge in the pulling itself.
Where does the pulling usually happen? I think most people picture the scalp, right?
The scalp is definitely number one, yeah. And then very commonly the eyebrows and eyelashes, so around the eyes.
Okay.
But honestly, it can happen anywhere there's hair. Face, arms, legs, anywhere.
Wow.
The main thing is that it's enough pulling to cause hair loss, you can see, and that, understandably, causes a lot of distress.
Okay, so that's what it is. But why does it start? Do we know the cause? Is there like one specific reason?
Well, as of now, pinning down one single cause. That's still a challenge for researchers.
Right.
The current thinking is that it's likely a combination of things, genetic factors playing a role, environmental influences too. It's rarely just one thing.
That makes sense. Seems common for complex conditions. You mentioned genetics.
Hmm.
Is there a family link? Does it run in families?
Yes, there's evidence suggesting it does. It seems to pop up more often in families where someone already has it, which points towards that potential genetic vulnerability.
Interesting.
And we also see it more often in people who also have obsessive compulsive disorder, OCD.
Ah, okay. So maybe some overlap in the brain pathways or something.
Potentially, yeah.
Yeah.
There could be shared underlying mechanisms.
And the environmental side. Things like stress, anxiety, do they trigger it?
Absolutely. Anxiety often comes up as a trigger for pulling episodes. Big stressful events, or even just kind of ongoing tension, can definitely precede the urge or make it stronger. But it's crucial to remember this isn't like a conscious self-harm thing. It's more like a way the body is trying to cope, albeit maladaptively, with those difficult feelings.
Right, a coping mechanism that ends up causing problems itself. Okay, so diagnosis. If someone thinks they might have this, how does a doctor figure it out? Is there a blood test or something?
No specific lab test. Diagnosis is mainly about recognizing that pattern of symptoms we've talked about and actually seeing the effects, the hair loss, the broken hairs.
Broken hairs.
Yeah, that's often a key visual clue. And it's also really important to make sure it's not something else causing the hair loss or the repetitive behavior.
Like body dysmorphic disorder. You mentioned that earlier. How is that different?
Right. Good question. That's a really important distinction. So with body dysmorphic disorder, the focus is usually on a perceived flaw in appearance. Someone might pull or pluck hair because they think it looks wrong or uneven or unsightly.
Okay.
With trichotillomania, the primary driver is the urge itself that need to pull. It might not even be related to how the hair looks at that moment. It's more about the sensation or the tension.
I see. So what specific physical signs might a doctor look for?
Okay, so they look for patches of incomplete hair loss. And within those patches, you often see hairs of different lengths kind of mixed together.
Like stubble.
Yeah, exactly.
Yeah.
You'll see broken hairs with blunt ends right next to new hairs growing in that have tapered ends. It gives it that uneven, stubbly look.
Right.
But interestingly, the overall density of hair follicles is usually normal. The hair is growing, it's just being pulled out. Also, a doctor might do a gentle hair pull test, just a light tug. With trichotillomania, it's usually negative. The hair doesn't just come out easily on its own.
Unlike some other types of hair loss.
Exactly. And the pattern of hair loss can be unusual too, kind of patchy or irregular, not like typical male pattern baldness, for instance.
It sounds like it could be tricky to spot, especially if someone's trying to hide it.
That's very true. There's often a lot of secrecy and shame tied up with this. People can go to great lengths to conceal the pulling and the hair loss.
Understandable. What about the official criteria, like from the DSM-5?
Right. The DSM-5, the main diagnostic manual, has specific criteria. Criterion A is basically the act itself, recurrent pulling leading to hair loss.
Okay.
Criterion B is that the person has tried repeatedly to decrease or stop the pulling. They want to stop, but struggle.
Right.
And criterion C is important. It means the pulling isn't better explained by another medical issue, like a skin condition or another mental disorder, like thinking the hair needs to be removed because of a delusion or, as we said, body dysmorphia.
Got it. I also read about this cycle, feeling tension before pulling and then relief or gratification after. Is that always how it works?
That pattern tension buildup, then pull, then relief is very common, yes. It's often reported.
But not always.
But not always, no.
Yeah.
It's important to know that some people describe their pulling as more automatic, almost unconscious.
Yeah.
They might be doing it while reading or watching TV and not even fully realize it.
Okay.
For them, there might not be that strong sense of tension beforehand or distinct relief afterward. So while the tension relief cycle is a common feature, it's not a requirement for diagnosis.
So it's more complex than just that one model.
Yeah.
Okay, what other conditions would a doctor need to rule out? You mentioned skin conditions.
Yeah, the differential diagnosis is key. They need to consider things like alopecia areata. That's an autoimmune condition causing patchy hair loss.
Right.
Also things like iron deficiency, thyroid problems, hypothyroidism, fungal infections like tinea capitis, or even traction alopecia from hairstyles that pull too tight. That negative hair pull test helps distinguish it from some of those where the hair is genuinely weaker or falling out on its own.
Can they do a biopsy, like take a small skin sample?
They can, yes. A biopsy isn't always necessary, but it can sometimes provide clues.
What would they see?
They might see signs of trauma around the hair follicles, maybe some bleeding points. They could see hair fragments stuck under the skin, empty follicles where hair was, maybe some deformed hair shafts. And sometimes an increase in hairs in the catagen phase that's a sort of transitional resting phase of hair growth.
But it sounds a bit invasive.
It is, yeah. Especially for kids, a less invasive approach might be preferred first. Like sometimes they might suggest shaving a very small discrete patch and then watching how the hair regrows. The pattern of regrowth can be quite telling.
Oh, that's clever. Makes sense, especially for younger kids. Now, you mentioned age groups earlier. How does trichotillomania look different depending on age?
Yeah, that's helpful for thinking about prognosis and treatment. Broadly, you can think of three groups. First, preschool kids. In really young children, the pulling is often quite mild, maybe more like thumb sucking, a kind of self-soothing or exploring textures, and often it just resolves on its own. Pretty benign usually.
Okay, that's reassuring. What about older kids and adults?
Right, so the second group is pre-adolescents through young adults. This is actually the most common time for it to start, think ages 9 to 13, maybe peaking around 12 or 13.
Okay.
When it starts in this age range, it unfortunately has more of a tendency to become chronic, lasting into adulthood.
And the third group, adults.
Adults, yes. If trichotillomania starts in adulthood, which is less common than starting earlier, it's more often linked with other underlying psychiatric conditions that might need addressing.
Got it. And I saw something about different types of pulling, automatic versus focused. What's that about?
Yes. That's a really useful distinction for understanding the behavior. So
Yeah.
automatic pulling is kind of like what I mentioned before, happening without full awareness.
Like fidgeting almost.
Kind of, yeah. The person might be doing something else, reading, watching TV, driving, and their hand just sort of goes up and starts pulling, almost subconsciously. This type seems more common in children.
Okay. And focused.
Focused pulling is more intentional. There might be specific rituals involved. Someone might actively hunt for a certain type of hair, maybe coarse or a different color. They might pull until it feels just right, or pull in direct response to a stressful thought or feeling. It's a more conscious process.
And knowing the difference helps with treatment.
Absolutely. Understanding whether someone's pulling is primarily automatic, focused, or maybe a mix of both can really help tailor the therapy approach.
Yeah.
Like, for automatic pulling, increasing awareness is key. For focused, maybe addressing the triggers and rituals is more central.
Right, that makes total sense. Now, beyond the hair loss itself, what other impacts does this have
Psychologically?
medically?
Oh, the psychological effects can be really significant. Low self-esteem is incredibly common. People often feel embarrassed, ashamed about their appearance, and they worry a lot about negative attention or judgment from others. This can lead to avoiding social situations, withdrawing.
So they might use coping strategies.
Definitely. Things like always wearing hats or scarves, using makeup to fill in sparse areas, developing elaborate hairstyles to cover patches, whatever they can do to hide it.
And the stress connection seems really strong.
Very strong. As we discussed, stress is often a major trigger. Some people find the urge lessens dramatically or even goes away when they're relaxed or on vacation in a low-stress place,
Oh.
only for it to ramp right back up when stress returns. And because people often don't talk about it, they can feel incredibly isolated, like they're the only one going through this.
Which probably isn't true given the prevalence numbers.
Exactly. There's also a higher risk of developing other issues alongside it, like mood disorders, anxiety disorders. And it can definitely strain relationships with family and friends who might not understand what's going on or why they can't just stop.
Yeah, that must be tough. And medically, are there other physical risks besides the hair loss?
Yes, there are. Skin infections can happen in the areas where pulling occurs, especially if there's also skin picking or scratching.
Okay.
Over the long term, constant pulling can damage the hair follicles to the point where the hair loss becomes permanent in those spots.
Oh, wow.
And the repetitive motion itself, the pulling action, can sometimes lead to repetitive stress injuries in the hands or wrists, even things like carpal tunnel syndrome in some cases.
Jeez.
And then there's something called trichophagia.
Trichophagia. What's that?
That's when someone ingests the hair they've pulled out.
They eat it.
Yes. And while often it might pass through without issue, in some cases, especially if a lot of hair is swallowed over time, it can build up in the stomach and form a hairball, medically called a trichobezar.
A hairball, like cats get.
Sort of, yes, but potentially much more serious in humans. In very rare but dangerous situations, this hairball can actually extend from the stomach down into the intestines. That's called Rapunzel syndrome.
Rapunzel syndrome.
Yes. And it can cause severe gastrointestinal obstruction and can actually be fatal if not treated. It really highlights that this isn't just a cosmetic issue or a simple habit.
No kidding, that sounds incredibly serious. Okay, let's shift gears slightly. What about the biology, the brain science, the genetics behind this?
Yeah, researchers are definitely looking into that. There's
Cool.
thinking that specific brain areas are involved. The basal ganglia, for example, which play a big role in habit formation, and the frontal lobes, which are key for impulse control, for inhibiting behaviors. There might be some dysregulation there.
So, like, the habit part is strong and the stop button isn't working as well.
That's a simplified way to think about it, but yeah, potentially. Some MRI studies have actually found, on average, more gray matter volume in certain brain regions in people with trichotillomania.
More gray matter. Interesting.
Yeah, and one study pointed to maybe decreased volume in the cerebellum, which might differentiate it a bit from OCD, where other areas are often implicated. Functional MRI, looking at brain activity, has also shown potentially decreased activation in some key regions, like parts of the basal ganglia and the prefrontal cortex during certain tasks.
So differences in structure and activity?
Potentially, yes. It suggests there could be differences in how these brain circuits are wired or how they function, contributing to the difficulty in controlling the pulling urge.
And the genetics, are there specific genes involved?
It's likely not just one gene. The idea is probably multiple genes contribute to a person's vulnerability or predisposition.
Okay.
Researchers have identified a few candidate genes that seem associated, names like SLPRK1, 5-HT2A, SAPE3, FOXP1. They're involved in various brain functions.
Right.
There was also that interesting finding in mice, a gene called HOXB8. Mice without it showed excessive grooming, kind of like hair pulling.
Has that been linked in humans?
Not directly, no.
Yeah.
As far as the latest research goes, there isn't a confirmed direct link between the human version, HOXB8, and trichotillomania itself. So an interesting lead from animal studies, but not confirmed in people yet.
Gotcha. Important distinction. Okay, so bringing this all together.
Yeah.
We know what it is, the potential causes, how it's diagnosed. Let's talk treatment. What actually helps?
Right. Well, the approach often depends on age. For those little preschool kids we mentioned, often it's just watchful waiting, conservative management. Many grow out of it.
Okay.
For older kids, adolescents, and adults, getting proper diagnosis and just increasing awareness is a huge first step.
Yeah.
Then non-medication approaches, especially behavior therapies, are usually the first line.
Behavior therapies like HRT, habit reversal training. I keep seeing that mentioned.
Yes, HRT is really considered a cornerstone. It has probably the best evidence base for success. It's often used along with medication, but sometimes on its own.
How does it work, basically?
It essentially teaches people to become more aware of their pulling when they do it, what triggers it, the sensations before it. And then crucially, it teaches them to substitute a different competing behavior instead of pulling when the urge hits.
Like clenching a fist or playing with a fidget toy?
Exactly, something incompatible with pulling. Cognitive behavioral therapy, CBT, often incorporates HRT, and overall, CBT tends to be more effective than just trying medication alone. It works for kids too.
Are there other therapies people try?
Yeah, several others show promise or help some individuals. Things like biofeedback, learning to control physiological responses like heart rate, which can link to anxiety.
Okay.
Other cognitive behavioral methods that might target specific thoughts or beliefs around pulling. Hypnosis helps some people. Acceptance and commitment therapy, or ACT.
ACT.
Yeah, that focuses more on accepting the difficult thoughts and urges without necessarily fighting them and committing to valued actions instead. And there's even a technique called movement decoupling.
Movement decoupling. Sounds fancy.
It involves learning very small, subtle movements that kind of disrupt the chain of actions leading up to pulling, interrupting the pattern physically.
Interesting. Lots of options there. What about medication? You said therapy is often better, but are there meds used? Any FDA-approved ones?
That's the interesting thing. Currently, no. The U.S. FDA hasn't specifically approved any drug for trichotillomania.
Really?
Yeah, but some medications are used off-label, meaning they're approved for something else. But doctors prescribe them hoping they'll help with TTM.
Like what?
Well, an older drug, clomipramine, a tricyclic antidepressant, showed some early promise, but the results have been kind of inconsistent in newer studies. Naltrexone is another one that's been looked at.
What about common antidepressants like SSRIs?
SSRIs like fluoxetine.
Mm.
Well, they've shown pretty limited usefulness, specifically for the pulling behavior itself. They might help if there's co-occurring depression or anxiety, but for the pulling, not so much, and they can have side effects. Behavioral therapy usually beats them for TTM. More recently, there's been some excitement around drugs that affect glutamate, a neurotransmitter. Things like N-acetylcysteine, or NAC, which is actually an antioxidant supplement, and memantine. Some studies suggest these might help reduce pulling by modulating glutamate levels, but again, more research is needed. And it's worth noting, some medications can actually make pulling worse for some people.
Oh, wow. So it really needs careful medical supervision.
Definitely. It's a very individualized thing when it comes to medication, and especially for adults. Treating any underlying psychiatric issues is really crucial too.
Makes sense. What about technology? Is tech helping at all?
It's starting to, yeah. There are mobile apps now designed specifically for TTM. They can help you track your pulling, identify your triggers, practice the strategies you learn in therapy.
Like a digital diary?
Kinda, yeah. And there's also work being done on wearable devices, like a wristband that can detect when your hand moves toward your head in a pulling pattern.
And it alerts you.
Yeah, maybe with a gentle vibration or a notification.
Yeah.
The idea is to increase that moment-to-moment awareness, especially for the more automatic pulling.
Cool. And we shouldn't forget support groups, right? They must be helpful.
Hugely helpful for many people, just connecting with others who get it, who understand the experience. That can reduce the isolation immensely.
Yeah.
Sharing tips, strategies, just knowing you're not alone,
Yeah.
that can be incredibly valuable.
This has been so insightful. Looking back, has this condition been recognized for a long time, or is it relatively new?
It's actually got quite a long history in a way. There are descriptions that sound a lot like it going way back, even potentially Aristotle in the 4th century BC mentioned something similar.
Wow. Aristotle.
Yeah. More formally, it was described in medical writings in the mid-1880s, and the actual term trichotillomania was coined in 1889 by a French dermatologist, François-Henri Halopo.
What does the word mean?
It's from Greek roots, trich for hair, tillo for pulling, and in mania, which back then implied more like madness or compulsion, but it wasn't officially recognized in the main psychiatric diagnostic manual, the DSM, until 1987.
So, quite a journey to formal recognition, and it seems like it's maybe getting more visibility now. In media.
I think so, yeah. There have been documentaries like one called Bad Hair Life that really explore what it's like to live with it.
Mm.
And it's popping up more in fiction, too. A character in the novel Whatever Love Means, someone in the TV show The Boys, apparently it's featured in the upcoming movie Smile 2.
Huh.
While these are fictional portrayals, they can help raise awareness and maybe, hopefully, reduce some of the stigma surrounding it.
Yeah, visibility helps. Okay, finally, let's circle back to prevalence. How common is it really? And does it affect certain groups more?
Right, so those lifetime prevalence estimates, again, are somewhere between about 0.6% and maybe up to 4%. It's a decent chunk of the population.
And onset age?
Most commonly starts in that pre-adolescent to young adult window, average age around 9 to 13, peaking maybe 12, 13.
Okay, and gender. You mentioned kids.
Yeah, interestingly, in very young preschool kids, it seems pretty equal between boys and girls.
But that changes.
It does. Once you get to that pre-adolescent to lesson onset group, it becomes much more common in females.
Yeah.
Studies show anywhere from 70% to over 90% female in that age range.
Wow, that's a big difference.
It is. And that female predominance continues into adulthood, though the ratio might drop a bit, maybe closer to 3 females for every 1 male.
Any idea why? Hormones? Societal pressures?
That's the big question. Hormonal changes during puberty could play a role, maybe societal factors. It's an area that probably needs more research to fully understand. Oh, and also that automatic style of pulling. That seems to be more common in adults. Maybe around 75% of adult cases involve mostly automatic pulling.
Fascinating demographic details there. Okay, so to kind of wrap this up, it's clear trichotillomania is really complex. It's not just one thing, right?
Yeah.
It's this mix of biology, psychology, environment.
Exactly. A web of factors.
Diagnosis involves looking for those specific hair loss patterns, the behaviors, and importantly, ruling out other things.
Right. Getting the diagnosis correct is key.
But the really hopeful part is that there are effective treatments, especially the behavioral ones, like HRT.
Yes. Therapies like HRT and CBT have a strong track record. There is definitely help available.
And remembering how hidden this often is. Seeking support, whether it's therapy or a support group, seems like a really vital and brave step.
Absolutely crucial. Breaking that isolation is so important.
It really leaves you thinking.
Yeah.
You know, understanding how habit, genetics, and environment weave together in trichotillomania. What could that teach us about other kinds of repetitive behaviors? Or even about mental health challenges more broadly?
That's a great point. There are definitely broader implications. Maybe exploring some of the resources out there for body-focused repetitive behaviors, BFRBs as they're called, could be a good next step for anyone listening who wants to learn more or maybe needs support for themselves or someone they care about.